Welcome, everybody, to the Dr. Mike and Shannon Show. And today, our question is, what is a clawback? I'm hearing a lot of grumblings out there from providers, practice managers about, oh, we're getting clawback. What is it? What are they talking about? Because it can affect patients as well. So they should understand what a clawback is also. So let's hear it. What is a clawback?
Well, let's talk about this because this is a real nasty word in the medical community, just so you know. So, this is generally tied to Medicare and Medicaid, but I will say I have absolutely seen it in Humana. I've seen it in, Aetna. The clawbacks can happen regardless of the insurance carrier. And essentially what it is that the insurance carrier, whether it be Medicare, Medicaid, or whatever, private or whatever the case may be, has given you, the doctor, money for a procedure that you billed for, and then have come back later and said, no, you weren't supposed to medically do that procedure, or that wasn't approved to be done, or that shouldn't be done at the same time as you doing this other procedure. And now we want our money back. We want to claw our money. And that probably is how it is to get that money back from us physicians, because we're already poor as dirt, to actually grab that money and back. And the challenge with this as a provider is that, for example, if you're doing the same kind of, let's say, lab test on every patient because you knew that you wanted to rule out something, and you were paid for that lab test, and it comes out later that that lab test is not something you should have done, or something that medically was necessary, or whatever the case, or shouldn't have been done on every patient that walks through your door, that clawback can be 6 and sometimes even 7 figures big. To ask for $1 million back, right, is a very, even especially now. And keep in mind, this might be something that you did over the last 5 or 6 or 7 years.
Yeah, and that money's been long spent.
Yeah, on and even in some
and not
situations,
necessarily in the doctor's pocket. I mean,
no,
there's
no,
involved. So it's
absolutely,
not going
yeah.
to the doctor.
We've had situations where I'll not name I'll protect the guilty, but that there's been a medical, let's just call it, an injectable that we would use, right? And the reimbursement for the injectable was $1,000, but the manufacturer billed us doctors $800 a test, $800 an injection, right? Now, imagine a situation where you've given $800 to that manufacturer of that supplier, that equipment, or whatever the case may be. And then, you're happy to get the $200. It's not a lot, but it helped your patients. And that's really what you're about, right? Only for 7 years later, for the insurance carriers to come back at you and say, you owe us all that money back. Not the $200 profit you made, the $1,000 that we gave you, that, 800 of it went back. So imagine how that would feel as a physician who was really just trying to do the right thing by your patients. And at the time, this happens after the fact. We had no knowledge of it during the time. That's why it's such an unfortunate thing to see clawbacks happen, because quite frankly, it's a little bit unfair to the physician. And believe me, we can't go back to that manufacturer and say, hey, we just got clawed back, so you need to give us our $800. You need to share in this expense. And I know there's been lots of lawsuits on that. And I got to tell you, Shannon, that it doesn't generally end well for the physician at the end of that, or anyone for that matter. It doesn't end well.
And it's affecting everybody, because I know in my area alone, just since the first of the year, several providers that I work with, they no longer take Medicare and Medicaid, and it not necessarily for the clawback reasons, but just because of everything in general, the time it takes to get the reimbursement, the clawback situation, among a lot of other things. that, you know, now patients are having to come in, and a lot of times these are patients who don't have the resources or the money. They're going to have to come in to providers, pay the cash up front, and then they're going to have to try to do the reimbursements. So it is affecting everybody. Now, as far as how a clawback is there a way for the Euroval system to be able to work in to maybe help with the clawback issue going forward with some of the being used as an assessment tool for providers?
So one of the things that's really, really important is that you've properly assessed your patients using assessment-based tools to be able to, on paper, justify some of the medical directions that we go. And we see a lot of physicians jumping right to things that maybe they should spend the extra time, if you will, to be able to properly assess patients, and assessments meaning it directs what we do on treatment. We know for a fact that the BRS, for example, if you have a certain delay in your latency, the Botox doesn't work at all. You know, botulinum A, toxin A, doesn't actually work for you. You won't be dry with it. You know, could you imagine a situation, and this has not happened, where Medicare comes back and says, well, you know, that didn't work and it wasn't medically necessary because you didn't do the proper assessment right up at the beginning to make sure that that was something that would work for that patient. You know, we are seeing this right now with Medicare dramatically. They are going after money because between you and me, Shannon, I think we're getting to the edge of broke.
There's a line.
Yeah,
Yeah.
we're getting close to that point. And so in order to be able to save what we have, in order to be able to save what we have, you know, Medicare is just getting more aggressive about things that maybe they could argue that, you know, weren't medically necessary. So doctors need to take this stance of more protective, and they are, but I think that you can do it even in your process flow in your practice to be able to make sure you're assessing appropriately to be able to, you know, counter these conversations. Because here's what will happen. You're going to get a call from someone and they're going to question what you've done in your practice. And they're going to question 5 patients, right? Like, why did you do this on these 5 patients? And based on those 5 patients, they're going to decide if you billing this code was medically necessary or not within your practice. And then they go and they pull every patient you've ever done for the last 7 years. And that's how they're going to decide if you're making the right medical choice or not. And that's it. You can get tripped up pretty easily, you know, pretty quick, because we
Right.
yeah, I mean, we have a tendency to do the same thing over and over again because that's medicine. That's how we practice medicine. And
Well, and the great thing about having the Euroval is, especially when we're looking at, you know, primary care, and of course, it depends upon what it is the patient's coming in for. But because of the fact that it does follow the Merck manual, I mean, we're looking at the Merck manual as recently as September 2023. So we're looking at just a couple weeks ago. You know, we're following that Merck manual. We're an actual assessment that gives data that somebody can have in that file. So if they come back 7 years from now, you have something there, concrete evidence of what you use to justify being able to have that done. And oh, by the way, the Euroval actually does have a really good reimbursement rate also for being able to use that, depending upon, you know, what code you're using.
well, and that's when we come into talking to physicians about, like, if they're in a clawback situation, how can they, you know, do the right thing and offset what's about to happen with them in the clawback. So you can take the existing Medicare patient you have, and instead of, you know, no longer taking Medicare, you know, start doing it the right way with proper reimbursement, and essentially gain that money that you're about to lose back. So you got to do something, right? You know, and I don't think the answer is just not taking Medicare patients anymore.
No, because I'm sure with Medicare, along comes everybody else in line.
Yeah. Oh
You're
yeah,
saying
no,
if
yeah.
they can see a way to get money back, they're going to be next in line with their hands out. So
Like I just said at the beginning of this whole conversation, Medicare is Aetna, Humana. I've seen this in other plays, and it's very difficult if you don't know if you're not doing everything you can to make sure you're doing the proper direction to treat. to be able to come back and say, no, this is the right way to do it. And this is why. It says it on the Merck manual. We have this progress note that has all of these white papers that backs up our choice of treatment based on assessment from the very get-go. You say that to one of those people that call you on the phone, they will move on to the next doctor. And that's ultimately what it's talking about, is making sure we're CYAing it when it comes to medical. That's very important.
And this has been a great topic because, again, we're hearing a lot of rumblings out in the area by practices, by providers, by the people who count the beans in the offices. So we're definitely hearing this out there, and we're hoping that this provided you with some valuable information. And any last words you'd like to put in, Dr. Mike?
Just keep punching out there, docs. We got to continue to be able to keep our nose to the grindstone, but we also need to make very, very smart choices about what we do. So I hope this has been helpful, not only to the patients that listen to us, but maybe some of the medical practitioners that are taking a look at what we're talking about as well.
Yes, because that's what we're here for. We're here to hopefully be able to provide you a powerful tool to be able to use in your practice to help fight the good fight. So we thank you very much. Please remember to like, subscribe, and share, and have a wonderful day.
Bye, everyone.